Hello everybody, welcome to the Med Center Show. My name is Joe Scott. I'm the President and CEO. At the Medical Center, every day we enhance life. And one of the people that does that is Dr. Andy Novick. Dr. Novick is the chief of our radiology department. Dr. Novick, tell us a little bit about yourself and kind of about your training and education.
Well, first, thank you for having me here. Good morning. Sure. I'm a radiologist and chairman of the radiology department at the Medical Center. I'm an interventional radiologist. I'll get into a little more detail about that later. I trained in New York at Mount Sinai Hospital, and I've been in practice in New Jersey for 27 years now, and came to the Medical Center a little over a year and a half ago.
Great. So you trained at Mount Sinai. So people really don't need to go to New York, right, to get great doctors? And we have a lot of great doctors on our staff who are trained in New York and, actually practice there every day.
Not only great doctors, but great technology.
Sure.
There's very few things that we can't do at the Medical Center that are done in New York City or any place in the United States for that matter.
Right. Now, most people talk about or think about radiologists as guys who sit in this dark room and just read those films, film after film. But you also do some other things, right?
Right.
So you're...
Well, we still like to sit in dark rooms.
You still
we still like to do that, too.
That's good.
But what an interventional radiologist is, we're a subspecialty of radiology that we do, I guess the easiest way to describe it is we do small surgical procedures.
Okay.
We try to make what normally would have been more difficult in the old days a easier, less invasive procedure for the patient. An example of that might be, in the old days, somebody might have had to have an open chest surgical procedure to do a lung biopsy. Okay. Nowadays, we'll do that with a very small needle and local anesthesia.
Wow. So you don't have to cut anybody, it's just a small needle?
Right. And that's just one example. I mean, there are many examples of what an interventional radiologist does.
Right.
But
now, so by having interventional radiology, you can avoid specific surgical procedures? Give us some examples of patients that came into the hospital.
One good example might be, last year, for example, we had a young pregnant woman, about 20 weeks pregnant, that had a massive blood clot in her lung and was doing very, very poorly. Couldn't breathe. We were worried about the mom. We were worried about the baby.
Sure.
We were able to put 2 small catheters, tiny little tubes, just barely could even see them, up through both groins, into her lungs, inject some blood clot dissolving medicine. By the next morning, mom was feeling great, sitting up, the baby was fine. 20 weeks later, had a normal, healthy baby who we got to visit.
And if we had not been able to resolve that issue, what would have happened, do you think?
Well, we had discussed that. One nice thing about Jersey City Medical Center is that we have a very good team approach.
Right.
When this woman came into the hospital, within about a half an hour, we had the cardiology department, we had the vascular surgeons, we had the thoracic surgeons, the high-risk neonatal pregnancy physicians. Everybody was down there in my office, and we were discussing what were the options with her. And the options were not very good.
Right.
The options, one is to just give a high dose of blood clot dissolving medicine and hope that she would do okay. But we knew that the risk to the baby would be at least about 20% of losing the baby and possibly losing the mom too. There's also the possibility of actually cracking the woman's chest open like you would see on ER.
Wow.
But that's a very, very high risk too. So we wanted to do something that would be easy for the mom and help the baby too, and that worked out very well.
So you read radiology films, and at the same time you do those life-saving procedures. So that's really, really cool. So what other types of radiologists are there?
Well, in our group, we have a very large radiology group. That's one nice benefit that we have. When we came to Jersey City Medical Center a year and a half ago, there was a very good radiology group here. But I think what we needed was more breadth. We needed a bigger bench, and that's one thing our group, University Radiology Group, has. We have 100 radiologists in our group. And in that group, we have specialists in not only interventional radiologists like myself, we have specialists in musculoskeletal, bone radiology, we have many neuroradiologists, we have specialists in pediatric radiology.
So there are radiologists that specifically just do neurological work, and that's all they specialize in, or just in musculoskeletal?
Well, they do a little of everything, but that's their subspecialty. I mean, it's such a large group. We even have specialists among the specialists. We have musculoskeletal people that only like feet, and other guys that only like shoulders. So one nice thing about that in a group like ours is we always have our radiology group staffed. But if somebody were to call out sick or somebody would be on vacation, we know there's always going to be another excellent radiologist there. Plus, if there's a very difficult case, I can send an email out to my group, and within a half an hour, I'll have 20 different opinions from all different radiologists in our group about,
what's the best course of
potentially complex case,
you know, I remember the days when you used to go get a chest x-ray and then they give you this big film and, you know, they'd slap it up onto the thing. We don't do that anymore, right? Everything is now digital. And
At the medical center, everything is all digital. What that basically means is that the old x-ray film has been replaced by either purely electronic equipment or an electronic plate. And the advantage of that is, for example, when we go up and we do the sickest patients in the hospital, we have to take x-rays on all of the patients, portable x-rays on all of our patients in the ICU that have just had cardiac surgery, for example.
Sure.
Very often, maybe 1 out of those 3 films that wouldn't get taken properly. Or we would have to go back upstairs and repeat. There'd be a delay in diagnosis, sometimes a few hours.
So they would take a picture, they'd wait for the film to be processed, then you'd put it up there and say, oh, it's not
no
right.
Good.
They got to go back up again.
Nowadays, the technologists, when they take the film, they could see the picture immediately on a little screen.
Oh, wow.
They know whether it's adequate or not.
Right.
And even if it's a little bit off, we can adjust it afterwards.
Right.
Just the way you would adjust it on your digital camera.
Wow.
We can adjust it the same way. So
Well,
very rarely do films get repeated anymore.
So since you have this network of 100 radiologists, can you then send those films out to the different radiologists so they can give you some other opinions also? So
Better than that, I don't even have to send them. We're all linked.
Oh, wow.
All of our physicians at all of our places are all linked on the internet now.
Okay.
So all I have to do is send out an email and say, can you look at Mrs. So-and-so's film?
Right.
And they'll look at it immediately.
Yeah.
The other advantage is, which is I think unusual that we have at Jersey City Medical Center, is that with this large group, we have 3 shifts of radiologists reading all night long.
Wow.
In most centers, even a lot of the large hospitals in New York City and around the United States, the big mega centers,
Sure.
the radiologists will work up to a certain time of day, go home, and they'll have outside companies reading, outsourcing these films, and sometimes they're scattered all over the world. And very often they do a very good job.
Yeah.
But there's no substitute for having your own radiologist reading 24/7.
Right. Yeah.
They know the way the hospital works. They know the way the ER physicians are.
Right.
They know what the ER physicians like. There's nothing like having your own people reading.
Well, especially I think at a place like the medical center, you know, we have trauma that comes in all night long. So if we've got our own group of radiologists who understand our process and our flow, that's much better. I think you're right. Before you came here, we used to outsource after 11 o'clock. I think we went to India.
Right.
And they had radiologists in India who were reading our films. Now we've got our own group. You understand the flow. You know, we do critical things at the hospital all day long. So I'm sure that helps, you know, the emergency room physicians, our cardiac surgeons, our trauma surgeons, to know that you guys are going to be there 24/7.
Right.
Yeah.
And of course, the interventional radiologists like myself are on call 24 hours a day. So if something happens at 3 o'clock in the morning, a gunshot, a knife wound, or a sick patient like I described before, we're available.
Sure. Now, one of the things that we're trying to encourage people is to make sure that, for example, women go have their mammography exams. Talk a little bit about the technology around mammography, because would you have special computer programs that look at those films also?
Well, our mammography is done at our Christy Kerr Women's Medical Center, where we have a beautiful outpatient center there. And we do everything related to mammography, women's health.
Right.
We do mammography, we do bone density studies, we do breast MR, breast ultrasound, biopsies, basically the entire gamut. And I forgot the question already.
So is there a special equipment that you use? Like, so after you do the mammography, right, isn't there don't you like take that film and then there's some kind of checker or something that?
Basically the way we read, and it's a little unusual in our group too.
Right.
We actually have 3 and sometimes 4 different readings on that same mammography.
Wow.
Because mammography is not a 100% pure science.
Right.
It's very difficult to read, and we like as many people reviewing the same film as possible.
Sure.
So what we use, at least in our group, we have the first physician will look at it. We have the computer looks at it. We use artificial intelligence computer systems to actually look at that. So that's a second reading. And then unbeknownst to the second reader, we have a second reader that comes in not knowing what the first reader saw or what the computer saw, reads it again, and then if either of those two disagree, we have a third doctor look at it. So basically what we're trying
you really
for,
you have a series of checks and balances that
we want to make sure we don't miss anything.
Right.
And that's really the goal, obviously, of breast care. Make sure you did not miss a breast cancer. It's hard enough to find them.
Sure.
We don't want to miss them.
Now, when you pull the image up on the computer, when you talked about the computer kind of looking at that image, can't you like enhance the images? And it's kind of like what you do with pictures at home, right?
Well, it's all digital mammography nowadays. In the old days, mammography, and actually we still, when we read mammograms, we like to read the mammograms with the patient's old films. And most patients will bring in their old films from non-digital centers. and you look at the old mammogram and you say, how did I even read that?
Yeah, well.
I mean, you put the new one next to the old one, you don't even know how you even made a diagnosis in the old days.
Right.
So, but now with digital, we're able to enhance the films, we're able to magnify, there's almost no limit to what we can really do.
And so, does the patient get a disc when they're done, or how do they get access to their films?
If they want it, we can give them a disc. If they're going to another physician, we
Right.
certainly can provide them with a disc. We don't print film anymore because the quality of the images on the disc are actually much better, and the doctor can also manipulate them.
So they could actually take that disc, like if somebody came and had a broken arm, they could take it to their orthopedic surgeon, and
Absolutely.
he can
And
take a look. Is that what you recommend?
Plus, also, doctors that are physicians that are on the medical staff can actually see the images from their office or from their home. They can dial into the hospital computers. They have a password. Obviously, it's all protected.
Wow.
And they can actually see the images on their home computer without having to actually even get the disc. So that speeds up diagnosis.
That's amazing. Think about the productivity and everything that, that you've been able to achieve just through taking those films and making them digital.
I mean, a good example for that would be somebody comes in with head trauma and they need a neurosurgeon, and before the neurosurgeon even comes in, he wants to see those films. So he could actually look at it on his, computer, he could look at it now on his cell phone.
Wow.
So technology is really progressing.
So even on their cell phone?
Even on their cell phone. We can also.
Wow.
We could actually look at the images on our cell phones too.
Well, that's, when you think about how far we've come, even in the last 10 years.
Not while we're driving, of course.
Right.
Not New Jersey.
You're not allowed to look at that image while you're driving. Please don't do that. We don't want you in our trauma center, so make sure you don't do that. Okay, thank you, Dr. Novick. We'll be right back. We're going to take a little bit of break, and we'll be back in a couple minutes.
Thank you.
Jersey City Medical Center, Hudson County's #1 hospital, as ranked by U.S. News and World Report. Hudson County's only hospital to receive an A safety score rating. Jersey City Medical Center is Hudson County's only hospital to receive the prestigious Magnet Award for Nursing Excellence. Make the #1 hospital in Hudson County your first choice for quality health care. Jersey City Medical Center. Visit us on the web at libertyhealth.org.
Newport, the luxury waterfront community on the Hudson River, offers the quality of life you deserve in 10 high-rise rental towers with amenities such as the on-site Newport Path subway, light rail and ferry service, Newport Town Square, 3 playgrounds, dog run, upscale restaurants, retail giants like Sears, JCPenney, Macy's, and Target. Morton Williams Supermarket is just outside your front door. A health and fitness club, spa, skating rink, and medical facilities are also on site. NewportNJ.com. Enjoy the New York skyline from Newport Town Square. Manhattan is just one path stop away or quick ride through the Holland Tunnel. Nursery and private elementary schools all on site. 12-screen movie theater at the Newport Center Mall. Want to visit Newport? Stay at the Westin or Marriott Hotel. Go to NewportNJ.com for details. Newport has luxurious towers, great restaurants, shopping, New York skyline views, schools, playgrounds, a marina and yacht club, gym, spa, fine wine, fine living. It's incredible. It's you. NewportNJ.com. Newport. Live like you want.
It takes more than a state-of-the-art medical facility to make a great hospital. It takes a team of dedicated medical professionals. That's the Jersey City Medical Center, Hudson County's #1 hospital. Medical teams consisting of New Jersey's top doctors, Magnet Award-winning nurses, and accomplished hospital associates, all committed to your good health. That's what you have at the Jersey City Medical Center. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center. On the web at libertyhealth.org. Jersey City Medical Center, Hudson County's #1 hospital, as ranked by the U.S. News and World Report. Why? Because of its patient care, not its bottom line. Jersey City Medical Center, for patients, not for profit. The Jersey City Medical Center accepts all patients and most insurance. At the Jersey City Medical Center, your health is our concern, not our bottom line. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center, for patients, not for profit. Visit us on the web at libertyhealth.org.
Welcome back. I'm Joe Scott, the president of Jersey City Medical Center. Welcome to the Med Center Show. We're here with Dr. Andy Novick, who is the chair of the Department of Radiology. And we were talking a little bit about mammography. And one of the things you mentioned was breast MRI. So tell us a little bit about, when would you use an MRI for? How does that work? What's the progression? You get a mammography and then do you automatically get an MRI of the breast, or how does it?
MRI, which stands for magnetic resonant imaging, it's a device actually that we use all over the body. Over the last 10 years or so, it's really come to the forefront in the use of diagnosing difficult cases in mammography. An example of that would be a woman with very dense breasts, where you basically really can't differentiate the small masses from the underlying breast tissue. Where MRI is very helpful because it really helps the cancers, if they're there, really just kind of jump out at you.
Wow.
Another example might be...
So what percentage of patients normally or have dense breasts? What percentage of women?
Well, there's different classifications of dense.
Right.
The very, very dense ones, probably about 10% or less.
Okay.
But even that is not necessarily for every patient. We also use ultrasound in diagnosing, breast masses in women with dense breasts. But MRI is particularly good in trying to find cancers in dense breasts, and also women that have known breast cancers that we're trying to work up that woman in terms of, are there other masses? What's the extension of the mass?
So the MRI really gives you a more specific, clear reading? Very
specific. And well, it's a different kind of reading. They're complementary.
Okay.
We use everything. We use mammography, we use biopsy, we use ultrasound, and MRI, of course.
So does every MRI machine, can every MRI machine do breasts? Be able to do breast readings?
Most of the good new ones, and obviously you have to have new equipment, and we have very good equipment at our outpatient center. We have a very new machine there. And you need special coils. Coils are basically like the antenna that we use for MRI.
Oh, I see.
And it has to be specially designed for it. Plus you also need special software, special computers to analyze it. In MRI you get a tremendous amount of data.
Wow.
And the doctor can't just look at that by himself. He needs the computer to actually put that all together into a format where you could actually see the individual images. And that's what our breast mammographers, we have special mammographers at our outpatient center that actually
these are radiologists?
Radiologists, and their subspecialty is mammography and women's health.
Wow.
And they deal specifically in breast MRI and mammography.
So that's really a differentiator for the Christie Carr Women's Center, right? Because we've got this special equipment, we've got the brand new MRI, it's open on one end, and people don't have to worry about that claustrophobia as much as in
I
that
think that
tube.
Is a fear of people in the old days. The machines were very, very claustrophobic.
Right.
And nowadays, even though it is a tube, it's a very short tube with a very, very wide opening, what we call the gantry, very, very wide opening. And even our claustrophobic patients are not too claustrophobic when they get inside that machine.
Wow.
It's a big advance, and the machines are getting bigger and bigger.
Do we do anything to help people who are claustrophobic if they have that worry? I mean, are there any special pieces of equipment?
Well, there are. There's actually music that they listen to that helps relax them a little. Some people will actually, and this is a small segment of the population that are really claustrophobic. We could actually take medication in advance to relax them.
Okay.
But nowadays, most patients really tolerate it pretty well.
Do.
Even claustrophobic patients do very well.
Wow, wow. Now, you see MRI centers all over the place, but we've got this special center with people who are specifically trained to read those types of breast MRIs through the Christie Carr Women's Center.
Correct.
And then we've got this breast coil that helps kind of them really read those MRIs. So people should be very careful about having a breast MRI and making sure that the center has the right equipment and the radiologist to read it, right? I mean, isn't that key as we move forward?
It's about the equipment, it's about the technology, and it's about the people.
Yeah.
And you need the people behind you.
Wow.
Another advantage is that we have, if we have patients that are really claustrophobic or children, we have the anesthesiologist can actually come down and actually put the people to sleep.
Wow.
We actually do that at the hospital.
Right.
Because, we want the patients to get full anesthesia.
Sure.
We don't do that in the outpatient center. But particularly with children who you can't tell a child to hold still for 10 seconds, let alone half an hour, there aren't that many places that are actually able to do that, and we can provide that service, which is a big service. And it's a big deal for the hospital to actually make that a commitment. You have to get all the equipment MRI compatible. These are hugely strong magnets. You can't just wheel a regular stretcher into the MRI center or a anesthesia machine. You have to get special anesthesia machines, special everything.
Wow.
So it's a big commitment for the hospital to have made that jump.
Able to do that,
but we are able to do that.
Wow. And so everything is non-metal, so it doesn't. So the magnet doesn't doesn't just pull all the stuff right to
We're
the
very
magnet.
careful about that.
So tell us the difference between an MRI and CT. Well, I mean, people talk about CT scans, and a lot of people from the emergency room get CT scans.
Right.
So what's the difference?
Right. The radiology department's actually made up of many different sections. MRI, we've talked about mammography and plain X-ray and interventional like myself. And then we have CT scan, ultrasound, and MRI.
Right.
MRI is magnetic resonant imaging. There's no radiation. It's basically you put in a very, very high magnetic field, and the molecules in the body flip around back and forth in the magnetic field and produce the images.
Wow.
So it's pretty cool.
Yeah.
But it's a different kind of an image. CAT scan is it's an X-ray, but it's a very, very specialized X-ray that actually produces slices through the body where you could actually see the individual organs. MRI gives the same type of pictures, but they complement each other.
Right.
You know, CT scans are easier to do, they're faster. In some respects, they're actually better. In some respects, MRI is better. So we use the both.
So when
that's our job, to try to decide which one is going to be better for which patient.
So is there certain things that you do in a CT that you wouldn't do in an MRI and vice versa?
Some diagnoses are just better. For example, in the lung, we're looking for small lung cancers.
Right.
That would show up much better on a CT scan, as opposed to if we're trying to find small detail within the brain, looking for a small brain tumor, that would be better in MR.
Oh, I see.
So but sometimes we use both. It depends on the type of disease we're trying to investigate.
I understand there's different, like there's a 16-slice CT and a 32-slice and a 64.
Right.
What's that all about?
We have very good equipment at the medical center.
Right.
Basically, in the old days, we had a machine that would, on the CAT scan, would take a single slice, and then it would move, and then it would move, and then it would move, and the patient could be in the machine for half an hour.
Wow.
Then as the machines have gotten faster and faster, and we talk about a 64 slice, it basically means with one spin of the tube, which takes less than 1 second to do, it takes 64 images, basically an image about this big.
Wow.
So when we have a trauma patient come into the emergency room and they need their entire body scanned, basically head to toe, a head-to-toe scan, if we would do that in one shot, would be maybe 15 seconds.
Wow.
It takes more time to wheel the patient in the room than it actually takes to do the scan. The advantage is not only the speed of actually doing the imaging,
right.
It's the quality that you can get because you could actually freeze the motion, freeze the breathing. In some respects, you could actually do CAT scans of the heart where you could actually stop the beating of the heart, catch it in between the beats.
Wow.
So you actually need the newer equipment, the faster machines to be able to do that.
That's amazing.
So even a patient in the old days, we'd have a patient that'd be moving, a head trauma patient, we couldn't get them to hold still.
Right.
Nowadays, if you could just hold them still for about 10 seconds, you get the whole study done.
So, and that CT scan, that's the one that's open on both ends, and kind of the patients don't have to worry about it.
Claustrophobia is not really a problem for that anymore.
No. And the images are that good, and the medical center has that really great equipment
We have very
that does it.
excellent equipment.
They do. Oh, that's great.
And we also use that.
We do, I should say.
We do. We actually use those machines to actually do biopsies. Like I was describing earlier in interventional radiology, we would do biopsies, do abscess drainages. An example of that might be, let's say a child came in with an appendicitis.
Right.
And if the surgeon went in, and let's say there was a ruptured appendicitis with abscess, if the surgeon went in, it would be very difficult surgery to try to treat that. Sometimes the patient would even wind up with an ostomy bag.
Wow.
Because the field had so much pus in it that they can't really do a good operation.
Wow.
So our job would be, instead of doing that, drain the abscess with a small little catheter, something smaller than the size of a pencil, about half the size of a pencil. Let the area clean up, let the infection get cleared, and let the surgeons come back 6 weeks later and do a nice, easy operation.
Wow,
so
that's
it's
amazing.
better for the patient, better for everybody.
Patients used to die from that kind of abscess, right?
Absolutely.
Wow, that's amazing.
And we do that in the CAT scan.
Yeah. Now, you also do ultrasound, and so, you got an X-ray, then you got ultrasound.
I'm happy to say we have some brand new ultrasound machines coming in.
Great.
We have good equipment to begin with, but we have some brand new ones coming in.
Great.
And ultrasound complements, again, our use. We use it in mammography. We use it to complement our CT scan, our ultrasound. Use for different purposes sometimes. We use evaluation for pelvic disease in women, to evaluate the uterus and the ovaries. Basically everywhere in the body we could use ultrasound, but we have some brand new equipment. And we also do biopsies and drainages with ultrasound.
Is that, that's what they use like when they're trying to look at babies and they rub that thing on the mom's belly?
Exactly.
That's the ultrasound?
Right, basically that gel is actually like what we call an acoustic coupling.
Okay.
Sound waves they can't travel through air. So what ultrasound basically is high frequency ultrasound,
Right.
that it goes into the body, bounces off, just like radar would be, and
Sure.
basically bounce off something and come back, and then the computer analyzes it. And we put the gel on there because we need to make a good connection between the machine and the surface.
Oh,
because if
okay.
there's air in between, then the sound
Then they
waves
can't see it.
immediately get
Wow.
lost. So that's why we put all that nice. And hopefully we warm the gel so it's not too cold.
Wow.
But
We were talking about some of the patients that we treat at the medical center. You recently had a case that was pretty critical that came in through the emergency department.
Right. Just last week, it was a good example of, I think, on how everybody, the good teamwork approach that we really have at the medical center.
Right.
We had a lovely woman came in complaining of a little bit of coughing up blood for the last couple of days. And it didn't seem too serious at the time. Within a few hours, that she was coughed up about 3 units, almost a quart of blood, which is considered extremely life-threatening. She was basically drowning in her own blood.
Wow.
And working with the anesthesiologist first, we were trying to decide what exactly we could do to help this woman. It turned out when we did bronchoscopy and we did our CAT scans and we saw that she had a tumor that was actually eroding into a bronchus. A bronchus is the breathing tube.
Okay. So the tumor was actually attached to it?
Was actually eroding right through, and that's where the bleeding
That's where she was
coming.
oh my gosh. And she
there's-
didn't know this for...
No, it actually happened very rapidly for her. At least,
Wow.
you know, the tumor had probably been growing for a while, but she didn't know about it.
Right.
We had discussed this with the anesthesiologist, the pulmonologist, the lung doctors, cardiothoracic surgeon, and trying to decide what would be a possible approach for this, because there really is no good treatment for this except possibly operating and taking her entire lung out. And what I decided with it, I thought would be the best, we'd be able to put in a stent. We probably heard of stents that put in all parts of the body, in the heart, for example.
Stent is like a tube that goes in?
Stent's like a little metal spring.
Okay.
But we needed a covered stent. So there are special stents that actually have like a silicone covering on them. And if I could put one of those in that bronchus, in that breathing tube, and seal that, not only would we open up the lungs so she'd be able to breathe again, we could stop the bleeding.
Wow.
Now, of course, nobody in New Jersey, we were calling everywhere, nobody had one of these stents available because they're not used too much anymore. We had one of our representatives run all around New York City until they found one stent.
Wow.
They was able to get us, and that day we went up to the operating room, we put that stent in, and her bleeding stopped immediately.
Wow.
So,
So she saw the tumor, so she has to get the tumor taken care of.
Now she's being treated for that.
Wow.
So
Wow, so we really saved this woman's life.
I think her
She would've-
family, you know, she came in not knowing she was really sick. Within a few hours, her family thought she was going to die.
Wow.
And by the next morning, her breathing tube was out. She was breathing normally and, you know, planning her treatment.
Wow.
So that's the kind of thing I think we could do at the medical center, and I think that's the kind of thing we could do as well as, you know, anybody in the big hospitals in New York City.
Well, you know, what's most impressive to me is that you recognize the need to work as a team with other members of the medical staff. And we have such great medical staff members now. We have some new open heart surgeons. I know you've worked with Dr. Krause, and now Dr. Pendergrass is there. I mean, those guys are great. Dr. Prendergast used to head the transplant program at Robert Wood, and now he's at the medical center. You talked about the vascular surgeons. They work very closely with you. It sounds like everybody kind of works together as a team to figure out what's the best approach for the patient.
And even though we're a big hospital, we're small enough that we still have that family kind of approach.
Right.
And I think patients, when they come to the medical center, they're surprised at how nicely they get treated. You can sometimes get lost.
Sure,
you know,
in a big hospital.
In a big hospital. And it's a lot easier to get all of the groups of people together at a hospital like Jersey City Medical Center. Get everybody together within 15 minutes, where it's not so easy to do in a big place.
In a big academic medical center. You know, it's interesting that you say that. You know, when you think about the big New York hospitals, they're so huge, and there's so many things that are going on there. Like you said, to get everybody together to have a consult like we can do. You know, we're 316 beds. We're actually getting ready to do some expansion and build some more private rooms. So that'll give us an opportunity to do some more things, but we're still half the size of those huge hospitals, and that really becomes a competitive.
It makes a big difference.
Becomes really a life-saving advantage for us, and that's really great.
If we could do things, we could do them quickly.
Yeah, no question. Dr. Novick, thanks so much for coming.
Thank you.
I enjoyed the conversation. You kind of gave us some insight into all the things that we do at the medical center. This is the Medical Center Show. Thank you for joining us. I would look forward to seeing Dr. DeGioia on our next show. Thanks.